I'll introduce myself first of all. So I'm Juliet Finnie. I'm one of the clinical leads at Oviva, and I'm joined by our first presenter will be Keren Miller, who is clinical lead for our diabetes remission programs at Oviva. Keren has been a diabetes specialist dietitian for more than 14 years. She also lectures in nutrition, and she's involved with the running of our remission programs in Oviva and also the evaluation and research arms of our Oviva remission programs as well. So Keren's going to share some insights into the Oviva remission programs here, some of our clinical trends, and then we're going to have some discussions as well with Dr. George Thom, who is the type 2 diabetes framework leader at NHS Tayside, and George also has a wealth of experience in leading diabetes remission research and has been involved in some of the key research around diabetes remission. So we're going to have a panel discussion that George and Keren can contribute to around the recent research in remission, and also some of the unanswered questions and where we're going to go with those as well. So that should prove to be a really interesting discussion. We're also really delighted to be joined today by Jeremy, who is been through one of our diabetes remission programs with Oviva, and just coming to the end of his 12 months in the diabetes remission program. So Jeremy is very kindly joining us today to tell his story about diabetes remission, about the program, his experience on TDR, total diet replacement, and food reintroduction, and all the ups and downs along the way on that journey. So we'll hear from Jeremy's story and also have the opportunity to ask some questions and get that real personal insight into what it's like to go through the program. So, and I will hand over to Keren to share a bit more of our data from our East Riding program and some of those clinical trends that we're starting to identify.
Brilliant. Thank you. Thank you so much, Juliet. And it's always a pleasure and a privilege to be here with you today. So I think at our last webinar in Scotland, we started to touch on some of our outcomes from our East Riding service evaluation of our remission program. And the East Riding is very similar to parts of Scotland. So I thought it'd be really useful to touch base on that again and see where we're at now that we've completed the 12 months with everybody who was enrolled with us there. We're then going to look at clinical trends. Dr. Thom, who worked closely on Direct, will share some of their learnings in Direct, and then I will touch on kind of some of the practical stuff that we've noticed in our data analysis. We'll look at managing expectations, and at that point, you'll probably and possibly have so many other questions about who should be eligible for this and who else should we be trying to do this with. So please keep those questions coming in and we'll make sure that we cover all of them. And at that point, it's going to be an ideal opportunity for me to keep quiet and to hand over to Jeremy. And I do feel absolutely privileged to have someone who's lived and breathed this to share their journey and their amazing success with us as well. And then, as Juliet said, loads of time for some panel discussions and lots of questions and answers. Feel free to pop them in the chat. That's possibly going to be the easiest way for us to pull out trends. But there should be plenty of time if anyone does want to ask a question. Thank you. So just a reminder for us academics about what is this definition of remission, and the definition that we're currently working towards, and this is what we're using, what was used in Direct, it's what we're using in the NHS England low-calorie diet remission pilot programs, is an HbA1c of under 48 on 2 consecutive readings at least 6 months apart. And during that phase, nobody should be on any blood glucose lowering medication, and that includes things like metformin. So that's the definition that we are currently working towards. It's the definition that was used in our East Riding data set as well. Next slide, please, Keren, because there has actually been some further debate around this topic, and they've revisited the definition. And this has been agreed and published in August last year at Diabetes UK. And what they are now proposing that we work towards is people to have an HbA1c level below 48 for at least 3 months and not taking any medication to manage their blood glucose over that time. Now, the data that I'm going to report on is using the original definition, but hopefully actually with this newly agreed definition, we'll be able to tick that remission box for so many more people. And we know that that is a huge motivator for lots of people. So I just wanted us to bear that in mind because there is still some discussion around that at the moment. Next slide, please, Keren. Okay, so this is the data. Now, East Riding is a very rural population. It's not a very ethnically diverse population. It's not that far from Scotland. And we've received some amazing feedback. We worked really closely with the commissioners. It was one lot of GPs that we worked with, so had really close relationships with them. But we achieved some amazing outcomes. Our patients went through their remission program, which was 12 weeks of total diet replacement, 4 weeks of food reintroduction, and then sustained calls, so monthly contact until the end of a year. If anyone did regain 2 kilograms or more in weight, they had the opportunity of an additional contact with their dietitian and an additional opportunity to do meal replacement products as well. And there are always so many questions when you propose to people that you're going to do 12 weeks of total diet replacement. People think people will drop out. There's no way anyone's going to do that. How can they do 12 weeks of not eating real food? What are the actual outcomes? Is this just a quick fix? Are we going to see some longer sustainable changes in people? And that's why I want to present the outcomes of this service evaluation to you. We had 28 people start the program. Now, 93% of those completed the 12 weeks of TDR phase. 93%. That is a really high achievement. If you think of usual diabetes and usual weight management services, we would be seeing a much higher dropout rate with those individuals. But the outcomes are fantastic. If you glance your eyes down to about halfway down that page, you see at the end of 12 weeks, the majority of those people their average weight loss was 13.7 kilograms. And for me, that's the key, that's the game changer, is those really amazing outcomes, climbing on the scales and seeing the results of your work make this really worthwhile. 89% of those TDR starters actually went on to complete food reintroduction. 68% completed the 12-month program. So there is a little bit of a drop-off as they move into the sustain phase. And some of that actually is because we noted people started living. Lockdowns were easing, people got back to work, people got back to life. It didn't necessarily mean that they actually weren't continuing to do it. They possibly just didn't need our support. However, there was still a really, really high adherence to that end of that 12-month point, with 68 people completing that program. Weight regain was not uncommon. That was noted in many people in the direct study, and we found 29% had regained 2 kilograms and decided to commence a refocus phase as well. But that average weight loss data is really exciting. Now, bearing in mind that this is not a research trial, this is real life. This was also not people coming into clinic. This was done in a remote delivery way, which meant we can reach people in a really easy way. It's also a much cheaper way to deliver the service. But we achieved some fantastic things despite this. Average weight loss at 12 weeks was 13.7 kilograms. People continued to lose weight because at 6 months, their weight loss on average was 14.2 kilograms. And they still continued to lose weight because average weight loss at month 12 was 14.7 kilograms. So yes, there's a really intense phase, but no, this is not a quick fix, because we continue to work with people as they reintroduce food and as they start living again. We can really embed these changes and make this something that can last for a long time for them. We didn't get loads of HbA1c data back, not yet anyway. We'll continue to work on that. But we did see improvements in HbA1c from baseline to month 12 in 75% of those where we did have HbA1c, an average reduction of 33.4%. Remission was achieved in 62.5% of those patients where we did have those double HbA1cs at month 6 and at month 12. Look at the meds changes. 96 prescriptions were stopped, with an average of 3.3 prescriptions stopped per patient. Now, in some situations, we did need to restart some metformin, and that was restarted in 6 participants, but nobody ever needed anything more than metformin. So those really expensive drugs were not needing to be reintroduced because people had lost so much weight. So my conclusion here is that this data demonstrates that this digital low-calorie diet remission program really results in amazing weight loss. We see great glycemic improvements and medication reductions at 12 months. And our engagement levels and that retention remains really high. We work hard to do that, but the outcomes really help keep people moving through the pathway as well. So really exciting. And let's move on to our next slide and kind of see the participant and primary care benefits from this as well. So there are lots of benefits for primary care. The feedback from the GPs we worked with was, this was just transformative. It felt innovative. This was so hot off the press that it was amazing for this GP practice to be able to offer this intervention to people. But going down this lifestyle route rather than medication first was an absolute game changer. And being able to get people off their medication was huge, not just for primary care and those cost savings, but really ticked a box for so many people as well. It was really accessible. The remote nature of delivery meant that we had more men taking us up on the service. To those of working age as well. Because we are working with people for a year and we have really high intensity coaching, so at those times where things are likely to cause problems, we're in contact with people up to 3 times a week. And that really reduced the burden on primary care, on GPs, on practice nurses, because the patients knew that actually they would have an experienced clinician in touch with them in that week. That really helped to reduce GP load as well. Next slide, please, Keren. There are a huge amount of benefits for our participants. They had a specialist at their fingertips. The use of our technology meant that they could ask questions at times that suited them and then review the answers at times that suited them as well. So that really, really helped them feel empowered. Appointments are flexible because of the nature of the way we're working. So we offer evenings, we offer weekends, and particularly in those really intense phase, they're not having to go to a clinic appointment and take time out of their life and work. The appointment happens when it's suitable and appropriate for them. And they have lifelong access to all the amazing, unique resources that we offer them. So they have access to our app for self-tracking. We know that's a real powerful game changer, and access to our learned content as well, which really supports them, not just now, but for the rest of their journey as well. Thank you, Keren. I'll answer some questions as they're coming in while Keren pulls up our next slide. I'm interested to know what was the blockers with getting HbA1c results. Many. So we've had various lockdowns while this has happened. So patients weren't going into their surgeries quite as quickly as they should have. Equally, there was the blood vial shortage, so that was a blocker. In many situations, they did go, but we haven't yet got the data back from primary care. So that's why we're going to, now that kind of things are settling and life is a new normal, we will continue to chase that. At this stage, we haven't got plans to follow. But watch the space, because if we can get more of our 12-month data, the GPs might be really keen for us to continue that. So watch the space. It would be wonderful to come back and share that data with you as well. So I'm going to pause for a little bit and hand over to George Thom, who is going to just touch on some of the amazing predictors that they found when analysing their direct data. Over to you, George.
Thanks, Keren. Yeah, so it would be nice to be able to predict at baseline which people are likely to benefit most, or who's likely to do well with an intervention such as this. I think that it's pretty fair to say that we lack good solid pre-treatment predictors of weight loss and by virtue of weight loss, diabetes remission. But we did a predictors analysis in Direct, and I think that probably the most important thing to say is that we didn't identify people for whom trying to achieve diabetes remission isn't a worthwhile target. So, but we did find some factors which were associated with people doing a little bit better than others. First thing to say is that, you know, with any weight management program, whether it's a TDR or whether it's another weight management intervention, there's a lot of individual variability. So Keren's presented the average weight loss outcomes using the Oviva total diet replacement program, but within that there's obviously a lot of noise, and the figure that is on the slide there shows in Direct the individual variation in weight losses. So you can see that in the intervention arm, which is on the right hand side, the mean weight loss was 10 kilograms at 1 year, which you can see as a black dot, but around that is the variability. So lots of people losing up to 20 kilos, and then just as many losing less than 10 kilograms, and some not losing any at all, and some people even gaining weight. So we know that within an intervention program, there's a lot of different factors affecting why people do well or don't do so well. Now, what we found was that men did marginally better than women. So at 12 months, weight loss was 11% in men compared with about 8.5% in women. And at 2 years, men had lost 8.5% body weight on average versus 6.6% body weight in women. Now, none of these didn't quite reach statistical significance, but it was close, and probably with more numbers you would see that it would reach statistical significance. But you can kind of get a sense that men maybe tend to do a little bit better using this approach. And we can hypothesize some of the reasons for that, but it's not down to the greater energy deficit, because we're looking at absolute weight loss here. And it's suggestive in Direct that because 59% of the study population were men, that the motivation for taking part was probably more around improvements in health, diabetes remission, coming off medications, and that perhaps may differ from females' motivations for weight loss, which may have a lot more maybe more related to appearance as a generalization, but perhaps less likely to be solely around health motivation. We also found that people reporting higher anxiety and depression scores lost less weight and therefore achieved less remissions. So you can see it at 12 months, that was 3.6 kilos, and at 24 months, 4.3 kilograms less weight loss than average. And again, it makes sense, I think, that for people who have, you know, more persistent negative mood states, that it's harder to achieve and to sustain a lifestyle program, which we all know requires energy and effort ongoing. And another key thing to take away, I think, from our perspective, was the effect of early weight loss. So even within the first month of the program, the weight loss achieved during that period was predictive of diabetes remission even at 2 years out. So early adherence to a program is a good predictor of long-term outcome. So that gives pause for thought also for, you know, reflecting on progress, you know, at 1 month, even at a couple of months, and whether or not it's the right thing for the individual. Probably the strongest predictor from a remission point of view was the number of diabetes medications prescribed. So for people who were prescribed 2 medications or more, the chance of remission was less. And I think that's a marker of disease progression and reduced beta cell capacity, although diabetes duration was not a predictor of remission in and of itself. We do know from other studies in bariatric surgery, people losing lots of weight, there's a proportion who are unable to to achieve diabetes remission, essentially because their beta cell capacity is unable to recover even with weight loss. So that was one of the key takeaways, I think, that when people are progressing in medication, so maybe going from metformin to something else, it's an indication that remission and the possibility for that is diminishing. But as I said at the beginning, it does not mean that remission is not possible and that people shouldn't try. So they were some of the key predictors within the analysis that we did as a post hoc.
Thank you, George.
Back to you if you want.
That's perfect. Thank you. And Keren will bring up our next slide. I've got some more trends to share. I guess they're more fun facts, if you like, compared to George's amazing data set. But we have started to look at our trends as well. And we found that most people weigh themselves on a Monday. And actually, this is a great lifelong habit for people. Many of them start their TDRs on a Monday, and we ask them to do a start weight on that day that they start. But actually, this is a great lifelong habit. It means they can pick up, focus the week. So a really great skill going forwards as well. We have reported to you today about our East Riding data set, but we have contracts all over the UK now, and we are finding that weight loss really does depend on the area. So East Riding's done exceptionally well. Some of our areas we are seeing a slightly different outcome, and so demographics, the socioeconomics, our relationship with the people referring to us and our commissioners, all of that might have an impact. So we're still learning so much from this. We have found no initial correlation between that 3-month weight loss and time from diagnosis to referral. So obviously we're not talking remission specifically here, because we know that the quicker we can get in there increases people's chances of remission. But actually we're seeing fantastic weight loss even if people have had diabetes for a long time. So don't let that put you off. This is a great opportunity for so many people, even if they've had diabetes for a little bit longer. Thank you, Keren. Next slide, please. Weight change at week 4 is a really good predictor. George has just highlighted what they found in direct, but we found just the same. Our current trend shows that patients almost double their weight loss from what they've achieved at that week 4 point. So those first impressions are good. Getting people off to a good start, seeing quick progress really, really does help. But that means that those first 4 weeks are so, so important. No huge surprises here. We see higher weight loss at 3 months is associated with improved blood glucose at month 3 and at month 9. And higher weight loss at month 3 is associated with an increased reduction in blood pressure at month 6. So, you know, that weight loss really does work, and it's brilliant to be able to show people their own data. It's not just textbooks saying you should lose weight and that's going to help these outcomes. Actually, they are doing it and proving that what the textbooks have said is right. But that really does help keep them move through that pathway. Another huge motivator is people are seeing these improvements in blood glucose and blood pressure, and they're on less medication. So absolute game changer. Delaying TDR start date seems to make no difference in their weight outcomes. And so we have found that actually agreeing a time, finding a time that is right for that person to start their TDR is really worth doing. If it means waiting till after Christmas, waiting till after a holiday or a wedding anniversary, actually they still do really well. Possibly they do better than if they had started when we had wanted them to start, because we want to get people off our waiting lists. Agreeing a time that's right for the patient is really important. Next slide, please. We've looked at our over and our underachievers, and we found that those that engaged more, so that was more app loggings, more learn content access, they made their appointments with their dietitians, they tended to do better. Of interest, though, is there was negligible difference between the number of weight measurements alone logged between the two groups. So the engagement goes beyond just checking in on their weight, because both groups were checking in on their weight. There's more to it. It's the app logging, it's the engaging with their dietitian, it's going to listen to the podcast that we've recommended as well. So just some kind of real interesting things that we've learned over the last couple of years working in our remission programs. Thank you, Keren. We can move on. Thank you. It's obviously a timing. Okay. What about those that don't achieve remission? And I can see the questions just come in about, do we talk to patients about these predictors at the early phase? And for me, managing expectations is so important. We have had patients who've achieved exceptionally well, and I'll read that quote to you shortly. We had a chap here who lost 13% of his body weight. He deserved to achieve remission, but he didn't. But actually, patients' feedback is usually it was worth a go. They've lost weight. They weigh so much less than they did when they started. They're on less medication. They're seeing improvements in glycemic control and their hypertension. And they've had a chance to focus on themselves for a year. And so, they learn new behaviors and a chance to really go back to the basics of nutrition as well. And so before I hand over to Jeremy, because it's definitely time to let our patient share his experience, I just want to read this quote to you. Oh, right. I tell you what, let's hand over to Jeremy. The main thing from that quote was really, this patient has fed back and said, things would have been so much worse if I'd not lost the weight. And although this patient has actually gone back onto some medication, he still feels it was worth a go. And you can see some words might jump out at you. He's having a bowl of stew rather than burgers and greasy food. He's enjoying tuna salad. So he's had a chance to reset, and that was worth a go. So I will put myself on mute and we'll hand over the tech to Keren and then over to Jeremy. Thank you.
Thank you, Keren. That's absolutely fascinating insights from both Keren and George there. So as I say, we're now delighted to be joined by Jeremy, who has been through this journey and probably has the best insights out of all of us into what this actually involves and how it feels day to day. So what we're going to do first is run a short video about Jeremy's journey on the programme, and then we'll hear more in detail from Jeremy himself and his story. So if Keren, when you're ready, you can run the video, please. And please do keep the questions coming in the chat. We are gathering those and we'll come to them after we hear from Jeremy. Thank you. Fantastic. Thank you. So many lovely outcomes to see there, and it has been a real privilege to work with you, Jeremy, through your journey. I wonder if you could just tell us a bit more in your own words of your story about, what led you to want to sign up to the programme, how it felt, what the journey was like, what the most challenging aspects for you were, what were the best outcomes and the most important outcomes to you, and what you feel you've achieved as a result of it, and just in your own time.
Yeah, definitely. I guess it all started when I was offered. My doctor in London, Dr. Gray, had just mentioned this program, and it was on the tail of being told my range was back in the diabetic, but it had been for a few months and I just hadn't had those results. And I'd been in that range maybe a year earlier, but had gotten out by trying to control my diet. So it was a bit shocking and I was very confused. And so when she offered the program, I said, yes, please, because I feel clueless when it comes to what was going on and what diabetes meant, because I only ever understood it. I had, family friends that were type 1. I didn't know what it meant. I didn't understand how it could come and go. So yeah, I just said yes, and I was very enthusiastic to find some support, knowledge, and education about it. Yeah, And joining just felt easy after that, especially with the support and contacts that I received, and selecting the the meal replacement and starting that. It was great. The first week was the most significant because it feels different from day one. I think a lot of my education for myself was just due to my schedule and lifestyle. A lot of times I wouldn't eat till the end of the day, and then I would have a large meal, and whether it was healthy contents or not, the largeness and the lack of food throughout, I think, was affecting how my body was processing that. And my blood pressure had been really high for 2 years, including medication that did nothing to it. And within a week, I was in the normal range, which just was shocking to me. And also, there was some weight loss in the first week, but that first week was just like, holy, expletive. That was really cool. Yeah.
Yeah, I think it is amazing to see the impact of that, especially considering it's you who's done that. You know, that there's no medical intervention, no drugs that have achieved that. That's been your actions that's led you to those amazing health improvements, and it's so inspiring to see. I'm just wondering about during that initial TDR journey, those first few weeks, how did that feel? Because I think people often wonder in terms of hunger, was it manageable? Did you feel that was really challenging? Did you experience any side effects, and how did you manage with that?
Yeah, I think I was surprised that because, as I'd mentioned, I was used to kind of like not having regular meal times or anything. I was surprised at being so satiated because of how many meals I had to take a day. And I know it was restricted calories in regards to anything I was paying attention to before, that I really wanted to be quite technical with when I could do those things and make the time to do that. And also the specific amount of liquids intake. So I timed it all so as to do it, throughout the day. Being that I was having all of that in a timed manner, I actually, for the first few days, was struggling to understand how to get in like the fourth meal replacement, because I felt totally satiated and not hungry at all, but wanted to do it because I knew that that extra 200 calories would probably trigger maybe being hungry the next day, but it never did. I found it very easy, and I found it surprisingly easy and satiating. Like I was totally full all the time and happy. Yeah.
Fantastic. I think that's really great to hear, and I think it helps a lot of people. There's quite a lot of dietitians on the call here today who are maybe wondering about supporting people, and often people do have questions about how am I going to feel, and to have that personal insight into it, that actually you don't feel really hungry throughout the period. A lot of people don't. That's really helpful.
Yeah.
The next phase I'm wondering about, Jeremy, is the food reintroduction phase. So for that, as somebody who's worked with a lot of people going through this journey, I found that a lot of people find that the most difficult part, and it's when there might be a lot of worry and anxiety about reintroducing food. I'm just wondering about how you felt. Did you have any specific worries about that phase, and how did that phase go for you?
I found that next phase to be the easier of the reintroduction, because it was like quite it was like the introduction of one meal a day at first, which I found to be much more easy to kind of comprehend and fit in. And the sizing and the weighing and the portion was like, it's very I found that very manageable and kind of easy to fit into that very, I'll say monotonous, and there's no negative tone on that, just the monotonous aspect of the meal replacement. Being able to slot in just one meal was, for me, a very easy transition and enjoyable, because it was like food, wow, it was really good. But the further phase I found to be more challenging. It was then trying to balance, I guess, the calories and portions with having to do it over a couple of meals. But not challenging in a way where necessarily it was a failure, but just more mentally. I had to shop more. I had to understand portions better, just because I was trying to buy food that would fulfill those new meals that I was introducing again.
Yeah.
May I ask a quick question, Juliet? So Jeremy, in that food reintroduction phase, which is really where we start to rebuild kind of your nutrition knowledge and your relationship with food, those lessons that you learned there about kind of portion control and shopping and making sure you had the right ingredients in, is that something you've continued to use as you've kind of moved out of that phase and kind of are living again?
Yeah, absolutely. 100%. I mean, to be honest, prior to the program, and it's not because of the program that I've done this, but with the support of the program, I was pretty much a vegetarian, vegan before, but not having a very healthy response from it all. So I introduced salmon and chicken and to work with the program because the meals recipes were quite specific to certain meats, and I was just like totally open to it. And I've done it before in my life when I was needing to, but I absolutely just, it changed everything. Like just because I didn't eat that way, learning the amount for protein and for vegetables and for the good kinds of carbs, like it was educational. Like every meal was interesting to me as to how that equals a really good size and amount and way of cooking. Yeah, and I've maintained that through as well.
Amazing, thank you.
Yeah.
Sounds like you really have those long-term strategies, which is exactly what we're trying to help people to have, that lifelong strategy for healthy living. And I'm just wondering if you feel about if you were to regain some weight at some point, which, for most people, life events will cause some level of regain at some point. Do you feel confident in tackling that? Do you feel that you have tools in the toolkit for tackling regains that might occur along the way?
Yeah. I mean, about a month ago, I moved, and in that process of a month, I had because the lockdown finished, one of my brothers decided to throw a surprise wedding, so I had family in. So I had like 2 weeks of like a family wedding, brothers visiting from other countries, meals, celebrations and all that, and then I moved house, which was that was a lot. So I was living on my cousin's couch for a week while we were moving, and it just caused me to have other people's menus, and I gained a little bit of weight, and it was just really easy because as soon as I was back in my space of purchasing my own stuff, it was just a simple transition back to the portion awareness and the menu, the recipes that feed the menu that I know work. Yeah.
Fantastic. So that real life experience of a challenging situation, but being able to get back on track, and hopefully that's built up your confidence. You can tackle those situations in future.
Totally.
Well.
Totally has.
Really,
Yeah.
really nice to hear. Just a couple of final questions for me is, one is, if you were to say to somebody else who is just considering doing a program like this, what would your advice to them be about how, whether to do the program or how to tackle it, to another person in your shoes a year ago?
Yeah, I mean, I would only have encouraging words about it. I mean, I've had an extremely positive experience. I found it to be, I mean, I don't know if it's just, how I approach things, but I found it to be like kind of the perfect scenario. Like to me, the support was incredibly important because I was feeling, even though I'm a grown man, I was feeling quite lost with understanding what was going on with the different medical situations I've been facing. And so this finding out about the diabetic, pre-diabetic diagnosis was quite overwhelming for me. So having the support of just like educational material in the app, and then the calls and the check-ins, and then information around why these things were working, but then also having the things to work with, the meal replacement and the the menus and stuff. I found it incredibly supportive. I'd even say therapeutic. So depending on the individual, I would definitely say go for it. And yeah, that's what I would say.
Yeah, that's really encouraging to hear. Thank you. And the last question for me is just a similar question, but thinking about all the dietitians that are on the call today and that are maybe thinking about the best way to support people like yourself on their journey, do you have any advice for them on what's the best way that they can support people like you to achieve everything that you have achieved?
I mean, I like the consistency. I don't know if, because everybody's so different, aren't they? Like, I feel like everything that occurred, because I worked with you, Juliet, throughout the whole thing, really, and it felt like a great fit. Like the program, the app, the educational material, our interactions, like it wasn't too much, it wasn't too little, it was consistent, it felt genuine. You had responses to some of the questions I had, and in a very supportive way. Nothing felt patronizing, and I needed as much information as I could get. Yeah. I mean, I guess, be sincere and authentic, and I guess in a way hold people to, really put the onus on the individuals if they're getting the support to step up and share what's actually going on.
Fantastic, thank you. That's a wonderful insight to share, and truly it has been a privilege to work with you on your journey, Jeremy, and see everything that you've achieved along the way.
Yeah, it's been great.
Thank you. Thank you so much for sharing that story. I'll ask anybody who has questions for Jeremy to pop them in the chat just now. And we'll put a couple of questions to Keren and George just now while everybody's maybe adding some questions for Jeremy, and then we'll come back to you, Jeremy, with any questions that we have then. So Keren, there was a question around insights into the combined effects of TDR and GLP-1 and any experience of that. Is that something that you could pick up on, please?
Yeah, with pleasure. The meds often get a lot of questions, and it's often what makes the GPs quite cautious, because in the majority of cases, patients will be stopping almost all, if not all, of their diabetes meds and quite a few of their antihypertensives on day one of starting their TDR. Now, a GLP-1 is actually safe to use with the meal replacement approach. There's some meds that are not safe to use. So sulfonylureas, glinides, SGLT2s are not safe. Now, the first two, the main reason is a hyper risk. People are only on 800 calories, so there is just a huge hyper risk if they continue to take those meds. So we stop all sulfonylureas and glinides before starting TDR, so on day one of starting TDR. SGLT2s we stop because of the risk of ketosis, the risk of ketone production. Again, people are only going to be on 800 calories. Now, your GLP-1s could potentially be safe, but they are doing a lot of what we're trying to achieve in a meal replacement approach. So we're trying to reset someone's appetite. We're trying to get people to be aware of their hunger signals and the triggers to eating, which a GLP-1 is often doing as well. Now, our approach is far cheaper than GLP-1s. We have done it, but in the majority of cases we don't, largely because cost saving is so important, and we want to give this meal replacement approach a proper chance. And I think if we do it alongside GLP-1s, that we're not going to get the true benefit. George, would you agree with that? Is that what you did in Direct?
Yeah, so we stopped all anti-diabetes medications at baseline. Obviously, if someone's on a GLP-1, then you can't infer remission from that, and the trial was set up to look at diabetes remission. I think what I would say is with GLP-1s, a hugely important role for weight loss maintenance. So we know in people with obesity, there tends to be dysregulated appetite regulation, so reductions in satiety hormones. So after weight loss, production of satiety hormones goes down even further. So in some people, that's a predisposition for body weight regain. So I think that there's been several trials actually which have shown that GLP-1s given as a weight loss maintenance strategy is far more effective than just continuation of dietary and exercise efforts. So we know that there's a huge element of genetics in regard to obesity. We know that there are physiological adaptations to weight loss, and so therefore, if we can address some of the underlying dysregulated biology, if you want to call it that, after weight loss, then I think that that's a good thing. I think Keren makes the point, obviously, that GLP-1s are quite expensive, but there are more treatments coming on sort of line, and will do over the next probably few years. So I think that we should definitely be using those things. People will maintain their weight losses much better by using these treatments. But obviously it's like diets. They're not for everybody, and some people don't need them. But it's not this is not all about willpower. You know, we need to try and help people to sustain the positive behaviors that they're making. So it's a combination, I think, of lifestyle change, and supporting people in that lifestyle change with medications.
Thank you.
Fantastic. Thank you. One of the trends and themes that's come up in the questions is around the differences between males and females, and especially in that food reintroduction and weight maintenance phase. So we've covered the differences potentially in the initial weight loss, but have you seen any differences, either George or Keren, in the food reintroduction phase and in weight maintenance in terms of outcomes between men and women?
I'll let you answer first, George.
I mean, I can't speak to exactly food reintroduction. It's fairly short phase, but just what as presented, the 12, the 1 and 2 year outcomes in direct indicate that men did marginally better, but I would say it's marginal. You know, women did very well also. You know, so yeah, so I think that's really all. There's not a lot I can add, I think, to the data that was presented.
And I would feel the same in looking at our data. I think what's so important, and as I've said these words already, is managing those expectations, you know, building a really strong relationship with our patient from the start so we can set them up for success. So, you know, are you a single mom and you're the one doing the cooking and the shopping for the kids? And actually that makes it very challenging to then, you know, do this. But equally, are you a single dad having to juggle all of that? And it's asking those questions, is getting to know your who is in front of you and coming up with a strategy together. And I think if you can identify potential barriers early, then you can actually problem solve together. And it's that problem solving that really sets someone up for success, not just now, but in the future as well. So we know that men and women have different relationships with food. And as George said, actually different reasons for sometimes losing weight. But I wouldn't say that that's a barrier. I think we can work with whoever's in front of us, but it's taking the time to get to know people.
Fantastic. So I'm just going to pick up a couple of questions quickly myself. So around Nicola's question about stopping BP meds and GP resistance, mainly no. Occasionally there would be some resistance from GPs, but that's why we would have a strict monitoring policy for blood pressure. And if we did see any drops in blood pressure that were a concern, if you go back to the GP at that stage, they're usually very happy to then make the reduction based on that evidence. In terms of the nutritional content of the TDR products, those can be found on the product websites if anyone's looking for those. Products such as Nestle Optifast or New Ultralife have websites, and all the nutritional content is available there. A question for Jeremy now from Alison, who's asked about digital tech, and obviously you used the app. We communicated back and forwards on the Oviva app over the TDR period and food reintroduction. Do you feel that people doing a program like that would need to be proficient in digital tech to be able to access a program? If you share your thoughts, Jeremy, and I'll add into that as well, please.
Yeah. I mean, I used the app and I had a smartphone, so I didn't need to learn anything there. And in regards to the app and the tools, which is the scale and the Fitbit, I literally don't need to do or know anything. I mean, I put the Fitbit on, I've never looked at it because it connects to the app and the scales feed the app. So I don't need to connect anything. And the app is it's laid out so simple. It's very user friendly. Yeah, you just go from the details that you're entering, and it's laid out quite easy. So I found it to be very easy. Yeah.
Thank you. I'm glad that you found it really user friendly, and I'll just add into that as well that if we did have somebody who was unable to access the tech, then we can offer phone coaching as an alternative, and that's the approach at Oviva that we would use if someone just didn't have a smartphone or was unable to use the tech there. We have another question for Jeremy, and I think we'll make the most of having you here to ask you a question. So this is a really interesting one. How do you now find socializing, eating out, and trying to adopt the healthy eating principles in those types of situations?
Yeah, I'll be honest, I feel more prone to going out now than I did before, just because I feel like I have more mental comprehension of healthy eating in general. So I kind of just know the things I'm liking and the size and the amount. And beforehand, I was just so uncomfortable and I felt so unwell within myself that I just didn't want to do that kind of stuff. So I'm doing it more now. And yeah, I mean, as someone who's been kind of vegetarian, vegan for most of my life, eating out's always been about trying to figure out what I could have on the menu. Now it's like I feel like I've got the whole menu and I just decide, the healthiest options, and I'm finding that part easier and more often. Yeah.
That's a really nice positive outcome to hear. And it's a whole quality of life thing. It's not just about food and health. It's actually about you enjoying life and that quality of life.